Hi guys, and thanks for watching. My name's Alan Gardner. I'm a senior lecturer in the School of Sport and Health Sciences. My background is I've been a registered nurse since 2006. That's adult nursing. I'm also an advanced clinical practitioner, and I've been an advanced clinical practitioner since 2014. I've worked at the University of Central Lancashire also since 2014, and I still practice in urgent care centres and primary care centres around the northwest. So the purpose of this video is that this is the first of a two-part series identifying and exploring the pharmacology of it's entitled The Pharmacology of Pain, but I suppose really it's the pharmacology of analgesics. So we're going to start by looking at NSAIDs and local anaesthetics. Considering the learning objectives of this video, by the end of the video we will have explored the mechanism of action of non-steroidal anti-inflammatory drugs. In particular, we're going to consider something known as the arachidonic acid cascade. We'll look at that in more detail in the next few slides. We're also going to appreciate the mechanism of action of local anaesthetic medication, which means that we're going to be looking at how local anaesthetics affect the transmission of neurological impulses from nociceptors to the spinal column. And we're also going to look at some pharmacokinetics, which means pharmacokinetics means how the body acts on a drug. So how is it absorbed, how is it broken down and excreted, and we'll look at the key components of pharmacokinetics. Before we can start to explore the pharmacology of our identified analgesic agents, we need to just briefly revisit the physiology of pain. To do this, we have this diagram to help us, and we can see from this that our pain nervous system pathways start peripherally with our nociceptors, and that these are free nerve endings that respond to noxious stimuli, such as this thumbtack in this diagram here. And we also know that we also respond to painful stimuli such as extremes of hot and cold, or chemical stimuli that lower the depolarization threshold. We'll talk about depolarization more in the next slide. But what we need is a wave of depolarization that travels along this long nerve fiber toward the spinal column via the dorsal root ganglion. So what that means is that our nerve pathway travels in the posterior, or the dorsum of the spinal column, and the ganglion is this part here, this collection of nerve cells. We start with our nociceptors, these free nerve endings, and they conduct a neurological signal toward the spinal column. They then synapse here with this second order neuron that then decussates to the other side of the spinal column, where it travels up the spinothalamic tract. We're actually going to leave our revision of this pathway at the spinal column, because the two pharmacological agents we're looking at today are the non-steroidal anti-inflammatory drugs and local anaesthetics, and they act on this peripheral nervous system here, whereas once we get to the spinal column and then travel up toward the brain, that's the central nervous system, and we'll cover that in the next video in this two-part series. So our wave of depolarization, we've said that we have a noxious stimuli that needs to stimulate our nociceptors. So these are free nerve endings that are sensitive to these stimuli, and that they then produce this action potential. What we mean by that is that this is our nerve cells' ability to allow positive and negative ions to flow in and out of the cell nerve fiber. What we're seeing here is actually, well, we have our nerve cell body here, and in this diagram we're actually seeing the the nerve transmission going the opposite direction to what we have with pain. Actually, that actually with our pain signal, it would be traveling toward the nerve body. So this nerve body here would be in our dorsal root ganglion. But for the purpose of this demonstration, what we're seeing is the difference between our two types of nerve fiber. That we have our A delta fiber here, so A delta fiber here, which is covered in this this myelin sheath, which is actually produced by this this series of what we call Schwann cells that wrap around the nerve fiber, and they cover it in this fatty myelin, which actually sort of nourishes and insulates the cell, much like the plastic insulation that we have around electrical wiring. But what we see are these gaps between the cells here, which are referred to as neurofibril nodes. So these gaps allow the transmission of ions. So in this case, it's mainly sodium ions that need to rush into the cell and produce this neurological signal, which is referred to as an action potential. A delta nerve fibers are extremely quick, something between 5 and 40 meters per second. That's the speed in which they transmit neurological signals, and that's because of these gaps between these Schwann cells. They're referred to as neurofibril nodes, and if we compare that to this this other fiber at the bottom, this C fiber, which is not subject to this what we refer to as saltatory conduction. Actually, that's what we refer to this as, saltatory conduction. This jumping of the action potential from one node to the next, whereas with the C fiber, it's a much slower signal, which travels at something like 0.5 to 2 meters per second, so much more slowly. So our A delta fibers then are responsible for very rapid transmission of a pain signal to allow us to respond to a sudden noxious stimuli, such as the thumbtack, and allows us to withdraw from that painful stimuli. It also allows us to be able to pinpoint exactly where that pain stimuli come from. If we contrast that to our C fiber, that this is a different experience of pain. This is our dull, achy pain. It's much more diffuse and less well demarcated. That's about all I wanted to say about the physiology of pain. I know that you guys have already been over this in the module, but this just allows us then to contextualize how our drugs work, so what the mechanism of action is in relation to this physiology. What we're seeing on this slide with the diagram on the right is what's referred to as our arachidonic acid cascade. This helps us understand how our non-steroidal anti-inflammatory drugs work. So these are drugs that act to reduce pain and they reduce inflammation. So we start at the top here with our membrane phospholipids. So this is the phospholipid bilayer that surrounds our cells. It keeps the inside of the cells within it, but it also allows the transmission of certain chemicals to go in and out of the cell. So for example, we mentioned our action potential in the previous slide, where we allow sodium to rush into the cell. So we need sodium channels that are large proteins that sit within the cell membrane. And actually we'll see those on the next slide when we talk about the action of local anaesthetic agents. As a response to our noxious stimuli, we have the breakdown of membrane phospholipids, and that these are then subject to this enzyme phospholipase, which turns our phospholipids into arachidonic acid. Now this is a free chemical that has no action of its own. However, this in itself is further broken down into other chemicals by these two enzymes here, COX. So that is an abbreviation of cyclooxygenase. So I'll just write that here, cyclooxygenase. So these are enzymes that catalyze the transformation of arachidonic acid into active chemicals. So we have prostacyclins, thromboxanes, and prostaglandins. So as you can see, there are two different types of cyclooxygenase, cyclooxygenase 1 and 2. Now, cyclooxygenase 1 is responsible for producing what we refer to as housekeeping prostaglandins. By this we mean chemicals that are responsible for things like renal blood flow regulation and the production of gastric mucosa. So these are prostaglandins that are sort of free throughout the body and just play a role in maintaining the body. However, cyclooxygenase 2 produces prostaglandins that are responsible for our inflammatory response and therefore part of our pain experience. And it's at this point that our NSAIDs are active. Actually, I made a mistake there. I'll just rub that out. So we have our NSAIDs here. NSAIDs. Okay. So our NSAIDs are active in inhibiting cyclooxygenase. So these are drugs like aspirin, naproxen, diclofenac, and ibuprofen. So these are they are what we refer to as non-specific cyclooxygenase inhibitors. So they inhibit the action of both cyclooxygenase 1 and 2, and that starts to help us understand why we have certain side effects. For example, if we are to inhibit both of these cyclooxygenases, we have the benefits of decreasing inflammatory prostaglandins, but we also, as a byproduct of that, decrease the production of housekeeping prostaglandins. And so our patients are at risk of gastric irritation and ulceration because they aren't producing the housekeeping prostaglandins that maintain our gastric mucosa. They're also at increased risk of renal damage because of the housekeeping role of cyclooxygenases in regulating renal blood flow. If we consider aspirin, for example, aspirin at low doses we know has a preferential effect on prostacyclins. So this will have the effect of decreasing platelet aggregation, and so we see less clotting basically as a result. Whereas other drugs like ibuprofen will have a more beneficial action toward the production of pro-inflammatory prostaglandins. If we look to the left of this diagram as well, that we can start to understand that if we inhibit the production of or the action of cyclooxygenase, that this kind of pushes our diagram over to the left, and so we see an increase in production of leukotrienes. Now, leukotrienes have a role in bronchoconstriction, and so this starts to help us understand why we can see side effects in asthmatic patients, that asthmatic patients are already inclined to inflammatory responses within the respiratory system, and so they're more at risk of bronchoconstriction. And so what we see is an increase in the role of leukotrienes, and so that's why we try to avoid non-steroidal anti-inflammatory drugs in asthmatic patients. So just to kind of recap this, because I know that this is probably new and hopefully it makes sense the first time round, but just to kind of go back over it briefly, that we start with our phospholipid bilayer that is damaged due to noxious stimuli, that this is then transformed by our phospholipase enzyme into arachidonic acid, that this is then cascaded down this right-hand side via our cyclooxygenase enzymes that then produces these three types of chemicals, and in particular we're thinking about prostaglandins, and that they have both a pro-inflammatory role as produced by cyclooxygenase 2 and a housekeeping role as produced by cyclooxygenase 1. If we go back over to the left of the diagram, that we see that arachidonic acid is also broken down into leukotrienes, and that leukotrienes have a role in bronchoconstriction. So this demonstrates how non-steroidal anti-inflammatory drugs act both in terms of their desired effects to decrease pain and inflammation, but also defines the way that they act in terms of their unwanted or side effects that we need to kind of mitigate, really. Hopefully that is useful and helpful. We can now move on to how local anaesthetics work. Earlier, when we looked at the physiological mechanism of pain and how a neurological signal goes from the nociceptors to the spinal cord, we said that there's a need for sodium ions to travel into the cell, and they need to travel through these large protein molecules within the cell wall. So these are sodium channel pumps. So sodium channel proteins, and they allow the transmission of sodium ions through the cell membrane and into the cell. So that produces this wave of depolarization, or this action potential. How local anesthetics work is, if we have a local anesthetic here, that these molecules are actually inactive or ionized, so I'll put just this negative symbol there, until they enter the cell itself. So they're highly water-soluble compounds until they reach the acid environment of the cell. Because they're ionized, that means that they are able to actually travel through the cell membrane and enter the inside of the cell, which then allows them to actually attach themselves. So I'll just draw this on here, local anesthetic there. It allows them to attach themselves to this sodium channel protein. Therefore, it kind of changes the shape of the protein, which means that our sodium ions here, if we just draw these on a bit more clearly, so our sodium ions are no longer able to actually travel through the channel into the interior of the cell. So this interrupts the transmission of that wave of depolarization that we mentioned earlier. This means that the noxious stimuli still exists. So if we take, for example, a typical use of local anesthesia would be in dentistry when we're having a filling or a tooth being extracted. That the transmission of that neurological signal, it still starts with the noxious stimuli. It still creates an action potential at the nociceptors, and that travels down the nerve fiber. However, at some point that nerve fiber is bathed in this local anesthetic agent, which, as I said before, is able to travel through the cell membrane and attach itself to this sodium channel protein, therefore blocking any further transmission of that neurological signal. So it can only go to a certain point, at the point at which the nerve block has been effective, that it will no longer be able to travel any further, so it can't reach as far as the spinal column, and it can't travel up the spinal column toward the brain. So this is drugs like lidocaine and marcaine, or bupivacaine is its non-proprietary name. So lidocaine has a much quicker onset of action, but a much shorter duration of action. If we compare that to bupivacaine, which has a longer period of onset, but a much longer duration of action. So that's why lidocaine is often used preferentially for small procedures, such as in dentistry, that we can have that rapid onset of action, but people return to normal much quicker. Finally, I wanted to introduce some of the principles of pharmacokinetics. I'm going to talk a little bit about these, and then we'll look at them in more detail and actually relate these to some of the drugs that we're looking at in the second of these two videos. Here we've got the 5 essential principles of pharmacokinetics, starting with liberation. And what this term means is this is how is the drug actually released into the into the body, whether that's the systemic circulation or it can be introduced locally, such as with intranasal corticosteroids, so that's steroid sprays into the nose, or it can be inhalants. So for example, we liberate salbutamol by spraying it from an inhaler and inhaling that into our lungs, whereas with oral medication it needs to be liberated from the solid pills that we can see here, and so that needs to then be broken down by our digestive tract, ready for it to be absorbed, which is the next of these these 5 principles. So absorption, this means how is the drug actually absorbed, and how does it get to where it needs to be. So absorption and distribution are kind of two very sort of linked principles here, that we need to absorb the chemical drug itself. So again, sticking with the example of oral medication, that drugs can be either absorbed within the stomach or predominantly by the small intestines. Sticking with the previous example I gave of inhaled medication, that obviously inhalants are absorbed within the alveolar of the lungs. Now distribution depends on whether or not does a drug need to be distributed throughout the systemic circulation, or does it stay locally. For example, inhalants are another good example, that predominantly we want them to act locally. However, we know that there's some systemic distribution, for example with inhaled salbutamol, that as that is distributed systemically, that as we get increased amounts of salbutamol within the systemic circulation, we start to see the broader effects of this type of drug, which is referred to as a beta 2 agonist. And so one of the side effects we see is tachycardia. We also see tremors in patients that have had too much of that. Another example of a locally acting drug that I gave before is intranasal corticosteroids, so steroids that act to decrease inflammation within the nose and paranasal sinuses. Again, we need those steroids to act locally, as opposed to if a patient's taking oral prednisolone, that the distribution of those two corticosteroids is different. That with oral prednisolone, we want there to be some systemic anti-inflammatory response as a result of ingesting corticosteroids. Metabolism here, now you might be used to the term metabolism, using it in a different context. For example, we think about our body's general metabolic rate, our ability to metabolize energy. However, in pharmacokinetics, we refer to metabolism as our body's ability to actually break down a drug. So obviously, once we've ingested something like our non-steroidal anti-inflammatory drugs, we know that they aren't in the body forever, that they need to be broken down over a period of time. Now, the majority of the metabolism of drugs is done by our livers. So when I say livers, I mean collectively as people. Obviously, we only have one liver as opposed to our kidneys. Now there's some small proportion of metabolism that's done by the kidneys. However, our kidneys have a much greater role in this final principle, which is excretion. So metabolism predominantly occurs within the liver, whereas excretion predominantly occurs within the kidneys. So excretion is our body's ability to actually get rid of the constituent parts. So after metabolism of drugs, we're left with what we refer to as metabolites. So that's the smaller chemicals that a drug is broken down into, and they then need to actually be excreted by the body. And this is predominantly done within the kidneys, with a small proportion excreted by within feces by the gastrointestinal tract. As I said before, we're going to look at these in more detail in the second video, when we can actually look at the pharmacokinetics of some of the drugs that we're actually looking at within these two videos. Hopefully this video has been useful and that you've been able to follow the mechanism of action of both non-steroidal anti-inflammatory drugs and local anaesthetics, and that you can now start to apply that to your practice. Thank you very much for listening, and I look forward to speaking to you again in part 2.